I am Wayne Levy. I moved here in 1985 and I never planned to stay here. I did my internship, I did my fellowship here, my wife fell in love with Seattle, and I begged to get a job here, as many people do. They don't necessarily recruit their own. And that was 1991, and I'm still here. And I am the medical director for the Regional Heart Center Clinic, and I'm also the fellowship director for the Advanced Heart Failure Transplant Cardiology Fellowship. And I like to do research, is what drives my passion, to be honest. And you'll see some of the research, and it would help if I spell correctly, but I missed that. Breating. Anyway, anemia and sleep disordered breathing and heart failure is the topic that I've been asked to talk about today. So in any lecture that we give, we're supposed to talk about disclosures. We did a trial with Amgen called RED-HF, which is reduction in reduction, I forget the acronym, but it was darbepoetin in heart failure for anemic heart failure patients, and we'll talk about that trial. We did a trial with ResMed for sleep disordered breathing and heart failure, and that's just been stopped. And then I was on the steering committee for the RED-HF trial with Amgen. So those are old disclosures, but since I'm talking about it, I thought I should at least disclose it. So anemia. Anemia is very prevalent in heart failure. If you look at data, we'll see some of it. It's about 20% in the outpatient settings and about 30% in the inpatient settings. We know that it's associated with morbidity and mortality, but we don't necessarily know whether it's a marker or a mediator. A marker means that it's something you treat and things get, a marker means that it's a marker, but if you correct it, it doesn't change the outcome. Whereas a mediator is something that's actually directly causative, so if you correct it, you will actually have a better outcome, and that's a little bit uncertain. We'll talk about erythropoietin treatment for anemia and heart failure, and we'll talk about intravenous iron. And at this time, there's, I think, better data for intravenous iron, as you'll see, and I think we underutilize intravenous iron for our patients in the ICU and on the floor, and I would urge you to really think about it in people who are inotrope requiring that we give inotropes to improve their cardiac output, but if you correct their anemia, you may get just as much improvement in their mixed venous oxygen saturation as treating them with an inotrope. And the beautiful thing is you can correct the anemia. They can go home with a corrected anemia. You can give them darbepoetin IV iron if you need to as an outpatient versus clomidobutamine is certainly a major issue. So if we look at the prevalence, it's 20 to 30%. It's associated with renal failure, so cardiorenal syndrome. It's associated with diabetes. It's associated with worse NYHA class. And what we do know is that treatment of anemia will improve regression of LVH and will improve symptoms. What we don't know is whether it really changes mortality. If you just look at a normal distribution, you have men and women. Women have a lower mean hemoglobin than men. And the definition that the World Health Organization has used is 12 for women and 13 for men. And so that's the definition that we use for anemia in our patients in the hospital or in clinic. There's all kinds of reasons that are postulated, and certainly when you're inpatient, one of the big causes is dilutional anemia. If somebody is volume overloaded, they have increased pressure, intravascular pressure, and it's a dilutional anemia. You actually diurese them, you actually get rid of fluid, and their hemoglobin will come up over time. The problem, we also are vampires and we suck blood out of them, so we actually can contribute to blood loss with that. There's thought to be impaired cardiac output, leading to impaired renal perfusion and decreased erythropoietin production, which is clearly common in heart failure. And there's impaired bone marrow, whether that's due directly from the cardiac output or for cytokine activation. We know that there's things called TNF and inflammatory cytokines that go up with heart failure, and those can directly suppress erythrocyte production. We know that there's iron deficiency, and in heart failure, when people have edema, they get gut edema, and the gut edema leads you to have diuretic resistance, and that's why we often give IV diuretics are better than oral diuretics, although with torsemide, you have such high bioavailability that that's not the case. But the same thing happens with iron. You actually stop absorbing iron, and you can do a very simple test to show this, which we used to do, but now we've just gone away from doing it because oral iron doesn't work very well in heart failure patients, and so we just give the intravenous iron. In a normal individual, you absorb about 1% to 2% of the iron. And so if you give a single dose of iron, it's roughly giving 30 days of oral iron. And so it's a huge advantage to give it IV, and you can give months of essentially oral iron in a very short time intravenously. We know that ACE inhibitors actually downregulate erythropoietin production, and in randomized trials, the hemoglobin is slightly lower in people on ACE inhibitors than people who aren't on ACE inhibitors. And so there's a whole pathophysiology. We don't necessarily have to go through this, but one of the things that I think is really interesting is that when I looked at databases, I thought that people who are anemic would have a low cardiac output, but in fact they have a high cardiac output, that they have an increased cardiac output to compensate for decreased oxygen delivery. And so if you can correct that anemia, then the cardiac output can come back to the normal range. And certainly in the acute decompensated heart failure patient, you may have mixed venuses come back at 40%, which is really, really low, but it's largely due to anemia and not necessarily a low cardiac output. So if you have swans, which we'll have in the unit, and every single swan we put in has a mixed venous oxygen saturating port, at least when I'm attending in the unit, I really focus on the mixed venous delivery of oxygen and not the cardiac output. And so that number, I think, is the most accurate in ascertaining whether or not patients have adequate oxygen delivery to their tissues, which may be from anemia, may be from low cardiac output, but you can actually measure that and see a change over time. And the beautiful thing is you can track back. And so you can actually see, something's happened now. What was it half an hour ago? What was it an hour ago? Because it actually stores both the cardiac output and the oxygen saturation. And of course, when you see them sit up, you'll see their oxygen saturation fall. Don't be concerned. They're walking, talking to you, they're sitting upright, and their mixed venous is 40%. You lay them back in bed, they're 50, 60%. It happens all the time, so don't be too concerned about that. So if we look at adults, about 9% of adults had anemia in the atherosclerosis risk in the community study, and it was more common in women, probably because they define the hemoglobin being a little closer to the mean than in men, and it's associated with worse outcomes. If we look in outpatients, depending on which study you look at and how they define it, the prevalence is around 20%, and in inpatients it's around 30% or higher, depending on how you define the anemia. This is data that we published now back in 2003, and ironically I just had lunch with Dari Mozaffarian, who was a fellow here. He is now Dean of the School of Nutrition at Tufts. But he was a fellow and published this with me, where we looked at a trial of NYHA3B for heart failure patients with EFs under 30, and you can see that the red line has the worst outcome, and that was a hematocrit of less than 35.6, and these are quintiles of risk. If we plot it here, the green line is the univariate, and what you see is a U-shaped relationship. So this is the nadir of risk is around 15, and as the hemoglobin goes down, the risk goes up, but as the hemoglobin goes up, the risk goes up as well. If you adjust for everything in the kitchen sink, what we found was a U-shaped relationship, and the nadir of risk was around 16. This risk was 12% per gram per deciliter. So going from 13 to 12 to 11 was a 12% increased risk. And on this side, it was a 36% risk. Now, what causes high hemoglobins?
Hemoconcentration.
Hemoconcentration. But why? I mean, most of our patients with heart failure are not hemoconcentrated. And so what will cause a high hemoglobin in these patients?
Overproduction.
I'm sorry?
Overproduction.
Overproduction, so if you actually have overproduction, and the reasons you can have overproduction could be polycythemia vera. So that's certainly something we think about, where you have inappropriate blood formation and you actually have hyperviscosity. If you start seeing hemoglobins of 18, 19, really think about that. You can have tumors producing it in the kidney. But the primary thing that you see in our patient population will be either lung disease, where you're getting hypoxic at night, or sleep apnea, where you're getting hypoxic at night. So you get hypoxia at night, which stimulates erythropoietin production, so they walk in with a hemoglobin of 16 or 17. So if you see any patient, probably in the ICU that you're seeing, anybody with a hemoglobin above 16, either think of smoking, because they are effectively removing the hemoglobin by carbon monoxide, but smoking, lung disease, or sleep apnea. So I will refer patients for a sleep study when I see them in the outpatient setting or the inpatient setting, because in the inpatient setting they should have dilutional anemia and other things. If they walk in with a hemoglobin of 16, 17, I'll refer them for a sleep study purely based upon that, because they have a high pretest probability of having sleep apnea if they have a high hemoglobin. This is just another study looking at anemia, and you certainly see that as your hemoglobin goes down, the all-cause mortality goes up in this trial. When we looked at the modes of death, the blue is deaths from pump failure, the yellow is sudden death, and this is other deaths. And clearly pump failure was associated with the low hemoglobin, and at least in our analysis, sudden death was associated with a higher hemoglobin, not pump failure death or other causes of mortality. This is another big trial called the CHARM trial, and this is people with low ejection fraction, and they again saw a U-shaped relationship for all-cause mortality, a U-shape for cardiovascular death, somewhat flat for sudden death, and then they saw for heart failure death, what we saw was that the lower was more heart failure death. This is ST elevation in infarcts, and again you see a U-type relationship, that the nadir of risk is around 14 or 15, and people who have a high hemoglobin or who have a low hemoglobin are both higher risk. So the question is, what do we do about it? So if we look at sort of the summary, anemia is present in 20 to 30%. It's associated with advanced age, with female gender, with higher NYHA class, with renal dysfunction, with inflammation, with cachexia, with a lower peak oxygen consumption, and with increased mortality and morbidity. But is it a marker or a mediator? So these are some of the studies showing that erythropoietin can actually be anti-apoptotic. And they can actually, there are receptors in the myocardium for erythropoietin, suggesting that it may have benefits directly on the myocardium to give erythropoietin. This is data looking at infarcts and giving rabbits, erythropoietin prevented infarct size. And this is looking at humans now, and this is functional class 1, 2, 3, and 4. And this is looking at the erythropoietin level and the hemoglobin level. And the hemoglobin here goes down, the erythropoietin levels go up. And the question is whether the erythropoietin goes up appropriately for the degree of anemia. And that's really, really important, and I'll show you a nomogram. And the nomogram is under comments, under ORCA. If you just click on that, you can find the URL for the nomogram. But it's very helpful because when we measure erythropoietin levels, they report out a normal erythropoietin level is something like 2 to 16. But that's a normal for normal hematocrit or hemoglobin. We generally don't measure it in people with normal hemoglobins. And so if somebody is polycythemic and they have a normal EPO level, their level's too high, and if they're anemic and it's normal, it's way too low. And so you need to look at a hematocrit adjusted erythropoietin level to know whether or not you have EPO deficiency. So this is some other studies looking at people with normal hematocrits and anemic, and this is looking at true anemia, actually labeling red cells and saying, do they have decreased red cell mass, or do they have a dilutional anemia? And I think it's all part and parcel. When you have heart failure, advanced heart failure, you often have a dilutional anemia, but they also have decreased red cell mass. We know that if you're anemic, your peak oxygen consumption is down. Whether or not that is part and parcel of their symptoms, their NYHA class, or whether it's contributing, I think it's probably a little bit of both. If you treat the anemia, you can actually improve the peak VO2, and you can improve the Minnesota Living with Heart Failure questionnaire. So this all led to a huge trial called Treatment of Anemia with Darbepoetin Alpha in Systolic Heart Failure, and I think it was reductions in endpoints with darbepoetin and heart failure, I think is what the RED-HF stood for. But this was an international trial where they randomized 2,278 patients, and they probably let people in with too high a hemoglobin. The hemoglobin was 9 to 12, and most of us don't treat hemoglobins of 12 with darbepoetin. The EF had to be 40% or less. They had to have symptomatic heart failure 2 or 3. And the goal with the darbepoetin was get it up to around 13 for the hemoglobin and no more than 14.5. When they looked at the hemoglobin, the average was a little over 11 and really did not change in the placebo group, and went up to around 13 and stayed there with the darbepoetin group. 0.75 micrograms per kilogram every 2 weeks was the starting dose. In the hospital, we used 0.45 micrograms per kilogram per week. Then you need to talk to the pharmacist because you want to round it to the closest vial size. And they come in, I think, 25, 40s, 60s, and 100s. And so you don't want to waste it because it's expensive, so you either round down or up to the vial size. At the end of the day, there was no benefit and no harm from correction of the anemia. When they looked at their primary composite outcome, death from any cause, death from a cardiovascular cause, or death from a cardiovascular cause or hospitalization for heart failure, it showed no benefit. This was really disappointing, but certainly what is nice about it is they did not see increased infarcts, they did not see enormous number of thromboembolic events, probably because many of our patients are already on Coumadin. And we don't know why this is. Is it because the hypothesis is wrong? Is it because they tried to treat to too high a hemoglobin, that the goal should have been treating 9 up to 11? Or is it just the wrong medication because of the venous thromboembolic events that are associated with erythropoietin agents? Now, Carrie would know more than I do, but I don't think we use erythrocyte stimulating agents, darbepoetin or erythropoietin, in bad patients. Is that a fair assumption?
No, I think we do.
You use it sometimes? Just be very, very careful in the bad patients. And the reason being is that we're concerned about increased thrombotic events with darbepoetin and erythropoietin. So we'll generally reach more for the IV iron and other things, and often let them appropriately or inappropriately walk around quite anemic. And the standard of care now in the renal population is to try to get the hemoglobin around 10. That they did trials looking at higher hemoglobins and there was no benefit and some harm. And so that's what I think they're doing in the bad patients as well, is not really trying to get the hemoglobin much above 10. So what about IV iron? IV iron, as we talked about, iron's not well absorbed in heart failure. And they did this trial in 2009 called the FAIR-HF trial. And they gave a formulation that we don't have available in the US called ferric carboxymaltose. And they defined iron deficiency different than most of us would define iron deficiency. A ferritin of less than 100, no matter what your hemoglobin level is iron deficient, and a ferritin between 100 and 299, if your iron saturation is less than 20%, was iron deficient. So most of the time we're looking at treating anemia. They looked at treating iron deficiency even if they weren't anemic. And the baseline hemoglobin, they reported here in grams per liter. We use grams per deciliter. But the baseline hemoglobin was 12.5 to 13. So most of these patients were not anemic to begin with. They had iron deficiency. The hypothesis is that iron deficiency is detrimental not just to the hemoglobin, but also to the mitochondria, because you need iron for your mitochondria to work. And so treatment of the iron deficiency can improve mitochondrial mechanics and oxygen production apart from correcting the anemia. So what they did is they gave intravenous iron, and they gave a dose weekly until they repleted them, and then gave it monthly as necessary to keep them repleted. And most of these patients needed about 1.2 grams of IV iron. And in the group who were treated, overall the people without anemia, their hemoglobin went up to 12.7 versus 11.8. And the people who, those were with anemia, without anemia, they remained about the same at 13. But their transferrin saturation was higher in the people who were treated than those who were not. I don't think, even myself, we have gone to treating the iron deficiency without the anemia. We're generally treating the patients who are anemic and then measuring their iron saturations. And to be honest, most of us are using, I think, an iron saturation of 15% to start with intravenous iron, and not an iron saturation of 20%. But this is what they did in the trial. I think this trial is pretty astounding because this is patient-reported global assessment where a higher value means that they feel better. This is the odds ratio for having an improved functional class, so their functional class improved. Here's a 6-minute walk test with treatment of their iron deficiency versus placebo. This is as much improvement as you see with CRT therapy, about 35 meters, which is huge. And this is a quality of life measure called the EQ5D, which improved more with treatment of their iron deficiency than with placebo. These are the adverse events. So they don't have statistically significant improvements, but if you look at the point estimates on most of these are actually trending in the right direction. So here is death, 3.4% versus 5.5. If you look at first hospitalizations, 17.7 versus 24.8. Hospitalizations for cardiovascular cause were almost half as much, and hospitalization for heart failure, 4% versus almost 10%. So certainly most of these endpoints are trending for benefit. So some people may argue that you don't have outcome data showing mortality, morbidity improvement, but certainly you have symptom improvement, and we'd like to do that. So they did a follow-up trial, which they called Confirm. The other trial was treatment for 6 months. This is treatment for a year. And very similar trial design because they treated for a longer period of time. It took they used more iron. Hemoglobin on average went from 12.4 to 13.4. Here is the odds ratio for improvement of functional class, which again showed more likely to improve if you got the intravenous iron. This is their 6-minute walk test. This is treatment versus no treatment. Again, substantial difference between the two. Fatigue reduced more with iron. KCCQ improved more. And the EQ5D visual analog scale improved more with treatment of the anemia. And this is looking at hospitalization rate for heart failure, and they had a lower hospitalization rate for heart failure with treatment than the placebo group. So we treat with iron, and the people that, I think the only people that you probably don't need to do it in are people who have acute GI bleed. Somebody walks in a hemoglobin of 13 or 14, they have an acute GI bleed. They've already shown you that they probably can absorb iron, and so they can probably be repleted with oral iron over time and not necessarily need to have intravenous iron. So in somebody who's anemic, measure ferritin, measure their iron saturations, check their B12 and their folate level. The LVAD patients are if you have people with mechanical valves where they may be having hemolysis. You can see this in perivalvular leak patients where they're tearing up their cells. You check an LDH and a haptoglobin. If you're thinking about giving erythropoietin, at least what our hematologists tell us to do is to document that they're deficient in erythropoietin. And that means measuring an erythropoietin level first to document that they're deficient. I generally reserve IV iron for an iron saturation of less than 15%. And a simple rule of thumb is it takes about 1 gram of IV iron to raise the iron saturation 5%. So if somebody has an iron level of 5%, they're going to need 2 grams to get them up to the 15% range. We aren't necessarily taking them up to the 20 or 30% range like they did in the FAIR-HF and the CONFIRM-HF. We maybe should, but we certainly need to treat the iron deficiency. And then consider erythropoietin or darbepoetin for true erythropoietin deficient patients, especially those listed for transplant. We don't want to transfuse them. They're often stuck in the hospital getting blood draws. If you give them darbepoetin, you can often prevent needing to transfuse them and get the elevated panel reactive antibodies and other things. And I think it's really important to remember that increasing their oxygen carrying capacity by correcting their anemia may do as much as putting them on dobutamine over the longer period of time. And we've certainly seen people that it may take a month, but you get their hemoglobin up from 8 to 10, and they can now come off their dobutamine and be sent home, and then you don't have to worry about the cost and everything else from the dobutamine and the increased risk of mortality from it. So the one other thing is if somebody has a low B12, you generally send a second test, which is a send out to Mayo Clinic called methylmalonic acid, which is actually documenting whether or not they're B12 deficient. You can go ahead and treat them, and we often start with oral B12 instead of the intramuscular B12, and then you check to see whether or not they're absorbing it. But that's sort of my background for treating anemia and heart failure. Any questions?
Why do you have to send another methylmalonic acid to the Mayo Clinic?
Because you may have B12 levels that are low, but you don't have true deficiency. And so then some people argue you don't need to treat them.
So do you start treating them before you get the
Yes,
result? Okay.
I do. And so it's just a confirmatory test, and the methylmalonic goes up if you're truly deficient. And so the level will come back and it's elevated. I think there's little harm in treating them with B12. It's just like 500 micrograms over the counter once a day. And certainly it can help with neurologic symptoms and other things, but many people are sort of borderline. So the true deficiency is down at like 180. I consider sending it in people who are 240 or less because some of them may actually be truly B12 deficient. If they're less than 180, they almost certainly are, but if they have a very low B12 level, they may still have B12 deficiency even though their level's not all the way down at 120 or something. Where you came from, did you use intravenous iron? Yes, yes.
Frequently.
So it's different places have different utilization of it, and I would just encourage you to consider using it because for you the problem is you don't see the benefits because you're going to be treating them. The benefits are going to occur on the floor or when they go home and they come back, but you can actually look back and often see hemoglobins of 8 or 9 go up to 11 with treating with intravenous iron. And then where we fall down, I think, is that we don't continue treatment as an outpatient. Mm-hmm. And so we are not necessarily giving a lot of intravenous iron except in the bad patients on the outpatient basis.
What did you mean by when you said if they have a GI bleed, then you know they...
Well, somebody who walks in with a hemoglobin of 14 is basically telling you they're able to absorb iron because they walk in with a normal hemoglobin. So they have an acute GI bleed. They may be iron deficient, but unlike the chronic heart failure patients, they probably don't have deficiency in absorbing iron. Now, there's no problem in treating them with IV iron to try to help replete them, but they're probably somebody who you can put on oral iron and they'll absorb it and replete over time. So if you see a previous hemoglobin that's pretty normal, they probably can be repleted with oral when they leave rather than IV.
When you're scheduling patients for outpatient, say they need an
They go to
infusion
4
IV.
South. They go to a place called 4 South for an infusion.
Okay.
And they come back and have that done as an outpatient once a week or once a month, however it wants to be ordered.
Okay.
So this is the nomogram that's on the comments when you order erythropoietin level. You can click under comments. They have a URL. You paste the URL and you get this nomogram back. So this is a normal level in, I think what they report back is something like 6 to 16, so sort of this range here. But that's normal for a normal hematocrit or hemoglobin. So as you become anemic, so if somebody has a level of 30, their normal EPO should be 100. If they're substantially below that down here, they are EPO deficient, even though their EPO level's above the normal range. If you have somebody with a hematocrit of 25, they should be up in the 500 range. So if they come back at 100, they still have relative erythropoietin deficiency, and it would be lovely if the lab would just report out the hematocrit adjusted EPO level and how many standard deviations they were below the normal, like they do for corrected retake counts or other things. So 2 numbers I put in my head just to make it easy. At a hematocrit of 35, they should be around 50. Hematocrit of 30, they should be around 100. So if you're measuring it, and most of the time you're going to be measuring it with hematocrits of 30 or less, or that range, they should have an EPO level of 100. If they're coming back substantially below that, they're EPO deficient. The people with acute GI bleeds, if you measure it, they'll often come back at 400 or 500. They have adequate erythropoietin, so there's no reason to give erythropoietin. And I don't believe in the Red HF trial they actually measured erythropoietin, because it would be very interesting to know which of the patients were truly erythropoietin deficient and whether or not they had more benefit than people who were just anemic for another reason. Sleep disordered breathing is very, 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 very common in heart failure. There are 2 types of sleep disordered breathing. One of them is obstructive sleep apnea, and the other is central sleep apnea, or I don't know what CSR stands for. This slide set is from ResMed. They sent it to me, so it's a lot of their stuff, but it's a very nice presentation on it, and I've modified it. But I want to thank ResMed because I don't do sleep apnea, and so it's nice to have them. So what happens in both of them is you have interruptions of flow. One is interruption of airflow due to obstruction in the airway, and the other is to the brain no longer sending out the signal. So you have Cheyne-Stokes type respiration with the central sleep apnea versus the obstructive. You actually have movement of the thorax when you obstruct. You have lack of movement of the thorax when people have central sleep apnea or Cheyne-Stokes respiration. That's what CSR stands for. If you look at obstructive sleep apnea and heart failure, you have respiratory disturbances and hypoxia, and you can actually trigger atrial fibrillation. So many patients will find out that they wake up with atrial fibrillation, and that probably means that they have obstructive sleep apnea that's triggering it at nighttime. We actually had one patient who was triggering his VT at nighttime from his sleep apnea. When we treated his sleep apnea, he was no longer triggering the VT, because arrhythmias should not be happening at night. They should happen during the day when you have high catecholamines and other things. If it's happening at nighttime, think about sleep apnea as being a potential trigger. You can get hypoxia, and hypoxia can lead to pulmonary hypertension, and that pulmonary hypertension can cause RV dysfunction. You can also have hypertension, and you can also have LVH resulting from it. So if we look at sleep disordered breathing in the general population, it's pretty prevalent. If we look at AHI, it's called apnea hypopnea index, and a normal value is less than 5 per hour. So stopping breathing for 20 seconds every 12 minutes. If it's at 15 an hour once every 4 minutes, that's considered mild sleep apnea. And if you look at these studies, up to 40 or 50% of patients who have stable heart failure will have sleep disordered breathing. This is why Richard Chang actually refers every single patient that he sees for a sleep study. And we probably should do outpatient Holter monitors type sleep studies, but they don't let us order those. And so unfortunately, we can't do simple sleep studies. So if you send them, they have to end up going to Harborview for an overnight oximetry, which is about $3,000-$4,000. They don't do the screening at home as a simple screening and then send those people out. Some people have central sleep apnea and some have obstructive sleep apnea. We aren't sure the best way to treat central sleep apnea, and we'll talk about a trial that was just stopped recently for harm, and so we aren't sure the best way to treat it. What will happen when you obstruct the upper airway is you actually will generate pressures inside the lungs. And where this is important for you as a clinician is that people who have significant sleep apnea will have elevated neck veins. So if you look at their CVP tracing, it is not uncommon, somebody with really bad sleep apnea, that they can have a CVP of 20. They breathe in and it goes all the way to 0. They breathe out and it goes back up to 20. This is the one time when the echo estimate of central venous pressure is often very wrong, because the echo looks to see that the IVC collapses. When they take their CVP from 20 down to 0, the IVC will collapse completely, and they'll say that they don't have elevated central venous pressure because they generate a huge negative intrathoracic pressure to collapse that IVC. You can't necessarily diurese people who have bad obstructive sleep apnea to a normal filling pressure, because when you do, you don't have adequate filling pressure. So just be aware that some people with sleep apnea, they may need a CVP of 10, and when you get below 10, they'll actually go into renal failure because they don't have adequate perfusion at low filling pressures. You need to treat their sleep apnea, but that doesn't help during the day. That only helps at nighttime. Now, when you put CPAP on, you actually increase the airway pressure to hold open the airways, but that's going to be transmitted back to the lungs just like PEEP does on a ventilator. And so you can actually elevate their central venous pressure by doing that, and so you can increase their CVP when you put somebody on CPAP pressure. And some people have CPAP pressures of 15. If you remember back, people often talk about PEEP, about 1/3 of PEEP going through, so that would be elevating their CVP by about 5. When people have acute decompensated heart failure, you actually can make their sleep apnea worse. And we did a trial where we were trying to find people in the hospital, treat them to see if treating their sleep disordered breathing would prevent readmissions. That's called CAT-HF. We were part of that trial. It's been stopped because of stopping the other trial. So one of the major risk factors is obesity. You have increased fat in your neck and you have decreased airway size, and certainly obesity, but it's not just obesity associated with sleep apnea. This is one of the more interesting concepts that I've seen, and that is that people have leg edema. When they lay down at night, the fluid in their legs actually goes up to their neck. Their neck actually gets bigger. You can actually measure this. So this is measuring neck circumference going up, 1-2 centimeters by the fluid going to their neck. That obstructs their airway. And this is the change in the lower extremity fluid volume moving to the neck when you lie down, and their sleep apnea gets worse. So if you can actually improve their volume status, you will prevent the fluid from moving to their neck and making their sleep apnea worse at nighttime. It's really hard. Yes?
Not only when they're perfectly sleeping.
Yes.
Oh.
Well, if they lay down. So if somebody's laying down even at 15 degrees, it may happen. It's just moving from the upright to the supine position. Lower extremity edema resolves. They get fluid in their lungs. They wake up with PND and other things. So one of the problems with almost every single study with obstructive sleep apnea is you have adherence. So you have people who take their medicines, they use their CPAP and everything else, so they have better outcome, and you have people who don't use their CPAP, but maybe they don't take their medicines as well and they have worse outcomes, and so you don't know whether it's the CPAP or whether CPAP is a measure of their adherence to their beta blockers, their ACE inhibitors, their diuretic therapy, everything else that's going on. And that's one of the problems with the studies. This is just looking at apnea-hypopnea index of less than 15 and greater than 15, and this was untreated, and this was normal, and they have worse outcomes. A very small study has a ratio of 2.8 for untreated sleep apnea. So this is the type of therapy that many people can be treated with. It doesn't have to be full mask therapy if they are mouth breathers, but this is called nasal pillows. So they're pillows that go underneath, so you don't necessarily obstruct reading or watching TV at night. You don't have something over your mouth. And so these are the types of things that can be much better tolerated. They now have machines that titrate the pressure. So you'll do a sleep study and somebody may need a CPAP of 12. And it used to be you'd set somebody at 12, but maybe they only need 12 when they're lying on their back, and when they're on their side, they can get away with 6. The machines can now sense this and titrate the pressure so that if they need less, they use less. If they need more and they need 15, it will actually go up to 15, and they have a range that they set it in, that they'll set the titration in, and those are called auto-titrating CPAPs. If you treat sleep apnea, you decrease sympathetic activity. This is measuring the measurement of the sympathetic nervous activity in nerves, and so you can actually show that treatment will decrease sympathetic activity. And I think this is one of the more interesting ones, and that is that the ejection fraction goes up with treatment of sleep apnea, very much like a beta blocker, which may be related to decreasing sympathetic tone. The control group did not. The people who were treated did go up. And this is looking at another study, looking at control and CPAP group, and the EF improves with treatment of their sleep apnea. This alone for me is enough of a reason, along with symptoms, to treat sleep apnea. This is looking at mortality. This is treated, this is untreated. Well, again, we don't know whether the people who were untreated were non-adherent to other therapy because they didn't want to be treated, but certainly suggested a difference in outcomes. This is people who are more compliant and less compliant, but it has the same problem about whether or not they're really adherent to everything else. So this is a polysomnography looking at the change in respiration, the change in the thoracic movement, abdominal movement, and other things, and this is central sleep apnea. Central sleep apnea during the daytime, if you have Cheyne-Stokes respiration of less than 10% and greater than 10%, the people who have more Cheyne-Stokes respiration during the daytime, not just at night, have worse outcome. This, to me, suggests that it may not be treatment of the Cheyne-Stokes, but treatment of their heart failure to make them better. This is looking at CRT therapy, and with CRT therapy, people have even shown that with just pacemaker therapy, you can actually decrease the apnea-hypopnea index for central sleep apnea with CRT devices. And this is looking at people who are considered non-responders, moderate or good responders to CRT therapy. The people who were moderate or good responders had greater reductions in their apnea-hypopnea index than the people who were non-responders. This is looking at mortality, and the people who had more apnea-hypopnea index had worse mortality than the people who did not. Now, there are different ways to treat it. One way is just giving people oxygen at nighttime, and so certainly oxygen can help. And I think we underutilize this for a lot of our patients who have central sleep apnea. They can't tolerate CPAP or BiPAP or other things, but maybe they really should be on home oxygen at night. This is CPAP, this is BiPAP therapy, and this is the thing called asymmetric servoventilation, which is trying to normalize the minute ventilation by basically having a CPAP, BiPAP type machine that if you don't breathe, it will actually force you to breathe. And this is one of the trials that's out there called CAMPAP. It was looking at CPAP therapy for central sleep apnea, and at the end of the day, it showed no benefit. They hypothesized that maybe it wasn't because they didn't use BiPAP or they didn't use other things, and the people who were adherent and had it suppressed did better than those who were not compared to the control group. But this is the newer machine that is, it's called a VPAP. It actually has asymmetric servoventilation to actually alter the breathing. If somebody obstructs, it will alter the pressure, and if they have central sleep apnea, it will actually alter the minute ventilation like a ventilator does. EF improves when you do that, but this is the trial that made everybody question it. And this is called SERVE-HF. This was a trial where they treated sleep disordered breathing, where the predominant form was central sleep apnea with adaptive servoventilation in patients with heart failure. They randomized 1,325 patients with central sleep apnea and heart failure, and the trial was stopped early when the all-cause mortality and heart failure hospitalization had a hazard ratio of 1.13, and the all-cause mortality was actually 10% on people treated versus 7% untreated with a hazard ratio of 1.34. We don't know why that is. We don't know whether, we don't think it's the machine. but it has led the sleep doctors to go back and using either CPAP or BiPAP or oxygen rather than using ASV ventilation in people with central sleep apnea. So the conclusion, it's common, considered in patients who snore. You will often have the nurses in the ICU tell you that people have witnessed apnea. If they do, they should have a apnea-hypopnea index obtained as a sleep study. If they have an elevated BMI or if they're walking in with a hemoglobin above 16, treatment with CPAP improves fatigue, the ejection fraction, and may improve survival. Treatment of central sleep apnea with AASV is potentially harmful. Use CPAP or BiPAP or consider oxygen. Sina Garib is a sleep doctor, a pulmonologist who has his clinic in the Regional Heart Center on Wednesday morning. And so he wants to see people who have sleep disordered breathing, who have cardiovascular problems. He's actually married to Nona Sutadenia, one of the cardiologists at Harborview. And so referring to him is a way to get the patient seen. And so you refer to the cardiovascular clinic, Dr. Garib, and they'll have him see Dr. Garib, and then he'll set up the sleep study at Harborview. There are new machines that they have available in the hospital, and they are called auto titrate CPAP. These are, if you write for a patient to use CPAP in the hospital, they'll bring in a big ventilator machine, and these big ventilator machines don't alter the pressure, so you will start somebody at 5, but maybe they need 10 or 15 centimeters of pressure. The auto-titrate CPAP will auto-titrate them between 5 and 20, and they're supposed to be able to get out apnea-hypopnea index and other measurements from it, but you just order under respiratory therapy auto-titrate CPAP, and then they can get these new machines which have a humidifier. They're about this big. They don't have the alarms that the other one does, and the patients really do like them better. And I've been using that on our patients on the floor, and you certainly can use it in the unit as well for people who forget their CPAP at home, or the ideal patients, and people who have a high index of suspicion. The reason to try it in the hospital is people try it, they feel better, they'll actually follow through doing a sleep study and actually using it as an outpatient. If they try it and they hate it, then they generally won't go through it. So if you start with the auto-titrate CPAP instead of the big machine that's more like a ventilator, they'll be more likely to like it and to use it. I wish I could tell you we had great outcome trials. We really don't. And it's one of the problems with almost all of the research is that the people who use it do better, but we don't know how much of that is adherence to everything else.
So do you order that auto titrate quite a bit then?
Yes.
Yeah. Okay.
So I ordered in people who have a high index of suspicion, and then try to get them to use it while they're in the hospital. Because if they feel better with using it, probably they'll follow through 90% of the time to actually use it. Because CPAP therapy, it takes time to adjust to it. So people may start out only using it 2 or 3 hours a day, then it's 4, then it's 6, and you can look to see how they're doing over time. If they bring their machine in from home, fool around with it, because often you can push the button and it will walk through information. The information can tell you a lot about the patient. They'll tell you they're using it, and you go to the information and they're using it 1 day out of the last 30 for 4 hours, and their average use per day is an hour per day. Other people, they're telling you they're using it, and they're using it 8 hours a day, 30 out of 30 days. It can actually give you a good idea about whether they're adherent to other therapy as well. And people who bring it from home often are adherent because they are used to using it. They'll tell you, I use it when I take a nap, I use it all the time.
Go ahead,
Yes.
you have a question?
Oh, go ahead.
Can you briefly explain the physiology behind how it improves EF?
Don't know. It
Oh.
may actually be a reduction in sympathetic tone.
Okay.
That if you reduce sympathetic tone, you reduce catecholamine surges at nighttime. It can be very much like being on a beta blocker. That's, we give people beta blockers, we reduce sympathetic tone, they change their myocardium and other things, so it may actually be that process that's leading to it. I don't know.
Okay.
But that's my thought process, is that you're actually a beta blocker-like effect by having people on CPAP.
What's the, you probably said it already, what's the incidence of central versus obstructive in heart failure patients with left ventricular dysfunction?
Many of the studies suggest that central is more common. To be honest, in most of my patients, it seems to be obstructive.
Yeah.
The central is often really, really end-stage patients, that they have horrible perfusion and they may have true central sleep apnea, but most of the patients that we're seeing seem to be more obstructive. They may have mixed, and it may be that they're primarily obstructive, and as they get decompensated heart failure, they get more central. And that's why the study we were using was using a machine that could treat both. But basically when the machine became contraindicated in people with heart failure with reduced EF or central sleep apnea, we could no longer use it in the trial, so the trial had to stop.
I think one of the biggest confidence builders I had when I first became a nurse practitioner in the heart failure clinic was sending all my patients for a sleep study. They all came back positive. It was great.
Yeah.
I thought I was doing a great job finding sleeping problems.
And you probably are.
Well,
I mean, the problem is,
I think most of them have. I mean, just because of the disease.
most of them have it, and it's probably, in the trial we were doing in the hospital, they had basically a band that you put around their chest called the apnea link, and they measured oxygen movement, and it was very simple. And it would be lovely to be able to do that at home, because it was a simple way to screen somebody. And if they have it, the question which I don't understand is, you have these auto-titrate CPAPs. They're $600. I mean, it's probably cheaper to just prescribe them the machine, see what happens, than to actually do the formal sleep study in the hospital. And even if they do the sleep study, then they do the titration. The auto-titrate will do it all the time. I don't really quite understand why they have to have the inpatient sleep study.
And they are doing the home screenings from Harborview now. They do
Good.
send it, but it's insurance based, right? So the Medicaid populations aren't getting it, but the Medicare and private insurances are. So because
That would be nice.
They can't keep up with the volume and the sleep clinic with.
I wish we could order them, because right now I think it's still limited to pulmonary doctors ordering them.
Well, see, also,
So I thought the sleep. So sorry.
I was just gonna say, there are quite a few instructions, like you have to be fairly competent to do the home sleep study. So,
As a patient.
as a patient.
Yes, you do.
Yeah.
So,
But I'm pretty sure some of this. I thought the the initial consultation with the pulmonologist. I thought maybe they make the determination on it.
Right,
That-
but I can't order it myself as a cardiologist without going through pulmonary. I don't think so. And so it would be nice for me, as I order a Holter, to be able to order a home sleep study. And then if it's positive, refer to the pulmonologist. If it's negative, end of discussion. We don't have to involve Dr. Garib.
I see what you're saying.
And that's what would be nice, or it's somebody in the hospital will actually order it in the hospital. They still have to go through a formal sleep study and everything as an outpatient.
Right.
Thank you.
But you can refer to the sleep medicine.
We can, and that's what we do.
Yeah, that's what I do.